Hi there, everyone. If you're tuning in, welcome. Just got the opportunity to present some work I did to you here for my master's dissertation. I was studying dietetics to become a registered dietitian, and I did family-based treatment for avoidant and restrictive food intake disorder in children and adolescents, and I systematically reviewed the current data and what's out there. The video in the corner, I'm hoping, won't hinder the format of the presentation. I think I've managed to sort of put it together in a way that the video won't affect it. So I'll just do some formal introductions. I'm Elliot Lee. I'm a registered dietitian, around 6 months into full-time practice now as a clinical dietitian. I've got a particular sort of interest and background in children and adolescents with learning disabilities, and I've got a sort of an area of expertise I'm hoping to develop in eating disorders. I sort of put this paper together alongside Ursula Philpott, which I'm sure many of you will know that name. She's a very prominent figure in the eating disorder dietetics world and very influential. And she's also a senior lecturer at Leeds Beckett University, where we developed this paper. And we're currently sort of drafting up for this to have a formal publication in a peer-reviewed journal relevant to eating disorders. And hopefully today I'll get a chance to sort of give you a background of the paper, some sort of clinical implications in practice, and just a little summary, and hopefully sort of provide some clarity on what's out there at the moment for treating children and adolescents with ARFID. But before I go into that, I just want to say a special thank you to Beat for the opportunity to use your platform to present this work, and sort of as well, a huge thank you for all the work you're doing and getting this conference going during these unprecedented times with COVID. I would love to have presented to you all in person, but this is the world we live in now, isn't it? And I'm really pleased to get this opportunity. So I'll just sort of start off with, avoidant and restrictive food intake disorder, or known as ARFID. I know this may be a sort of a refresh for some of you, so I'll go through this sort of quickly. I've got a timer just down here just to make sure I stay on timer within the 30 minutes. But it was sort of introduced as an official eating disorder in 2013 in a diagnostic in the Statistical Manual of Mental Disorders. But that's not to say it's a new eating disorder. It was perhaps an extension and expansion of, eating disorders not otherwise specified, and feeding disorders in infancy. But this, in 2013, it gave this significant eating disorder a real label. And from then on, there's been a growing body of research. And it's defined as the avoidance or restriction of food intake, which results in clinically significant failure to meet requirements for nutrition or energy intake. And this diagnosis provides a label for a heterogeneous group of individuals who are engaging in this restriction and avoidance to foods, but without the body image concerns. And that really forms a significant reason as why I sort of looked into the family-based treatment, because these feeding behaviours have manifested for other reasons and not the body image concerns perhaps other eating disorders do. So some of the features present for a diagnosis, which is listed within the DSM, firstly, significant weight loss or failure to gain weight, significant nutritional deficiency. So we've got the dependence on tube feeding or oral nutrition supplements, and then marked interference with psychosocial functioning as well. So it captures a sort of a broad range. But you can sort of see the impacts here of what for a child or an adult living with ARFID sort of experiences. And in practice, in dietetic practice, particularly in paediatrics, you have children presenting with picky eating and concerned parents, but this is far more significant, and has some real implications on an individual's both physical and mental health. The subtypes that we know in ARFID is the general lack of interest, the sensory sensitivity, avoidance based on a sort of aversion perhaps to a particular experience or something along those lines. And then we've got the mixed subtype as well, where the sort of the symptoms and results of having ARFID are from a mix of some of these subtypes. So just thinking about the treatment options. So because of the relatively new introduction of ARFID formally in the DSM, There isn't currently an evidence-based treatment suitable for all forms of the disorder. But that may also be because of the people with ARFID are a very heterogeneous group and diverse, largely individual, and presenting in all sorts of sort of different complexities, coexisting conditions. And although the Eating Disorders NICE guidance had an update in 2020, they sort of exclusively stated that the publication doesn't capture ARFID, as it is still a growing body of research, and having something suitable for all forms isn't there just yet. But some of the familiar ones that perhaps are used in other eating disorders and have been used in ARFID is the cognitive behavioural therapy, hospital-based refeeding, the adjunctive pharmacotherapy, and then the one that I've had a look at is family-based treatment, which I'm sure that many of you are familiar with those. So why did I choose family-based treatment? Well, looking back through the sort of the literature and other eating disorders, it's well established that family-based treatment in sort of the paediatric population, so 18 and below, they utilise the parents and caregivers and sort of place them at the centre of therapy to aid with intervention. And it was Dr. James Locke and his colleagues in 2001 that published the Maudslin family-based treatment model within the Manual for Anorexia Nervosa. So as a result of that, this model has sort of been adapted and applied to individuals and patients that have ARFID based on the theory. And just going back to the earlier point about they're engaging in these restrictive and avoidant feeding patterns without the body image concerns. And that's why I wanted to look at the family-based treatment as an individual treatment, because the model of this focuses on changing the eating behaviours through the parental and caregiver management, rather than the cognitions relating to weight or body image. So theoretically, there's that potential for it to have quite a high impact on the desired outcomes for those that have ARFID. I just wanted to highlight here that as I was formulating the proposal for this systematic review during my master's, I noticed that there were two authors that had published a systematic review just on treatment in general in avoidant and restrictive food intake disorder. And they'd recognised it is a growing body of research. There's sort of all sort of variations of study design and quality, but clearly there's been investigations, and this was the first systematic review to sort of capture the treatments together. So off the back of this, I thought, given my interest, sort of expertise, and some of the literature in some of the other eating disorders, I thought that it would be worthwhile having, having the time to investigate sort of one of the treatment methods included in this systematic review. So with that, my objectives formed. There were 5 key objectives. So, I wanted to analyse how family-based treatment was adapted to treat and improve clinical outcomes in those with ARFID, and in my group, it's 0 to 18 years old. I wanted to investigate the differences in treatment effectiveness across the subtypes. So the earlier subtypes mentioned, is there a subtype more suitable to receive family-based treatment, or is it a sort of a consistent throughout? But based on the heterogeneous population of those with ARFID, I thought this would be a good objective to include. I wanted to also analyse the use of family-based treatment in multimodal and adjunctive treatments. Given the complexity of some of those presenting with ARFID, it would be beneficial to see perhaps is it going to be good as a supplementary part of treatment where, other coexisting conditions, anxiety and depression, autistic spectrum disorder, they may be receiving other treatments to try and improve their feeding behaviours, and does family-based treatment really have a good impact alongside those? I wanted to examine the differences in family-based treatment effectiveness on clinical outcomes, and then just synthesise what's currently known and give some recommendations for future research. So just to briefly go over the outline, my PCOS formulation, I went for children and adolescents, family-based treatment. The comparison groups were available, but I did include case reports and case series because although it's a growing body of research, there's still quite limited sort of highly valid research in the randomised control trial. And then the outcomes I'm looking for, of course, weight gain, and then the other sort of, expansion of food variety, decrease in fear, improvement of psychosocial functioning. So some of those I'm sure that you probably come into contact with a lot in your practice. Criteria, nothing too sort of in-depth. I started the date range for the papers from 2013 on the basis of its introduction to the DSM. You know, pediatric population, I was including the multimodal and adjunctive treatments as well as family-based treatment in isolation. I did include the case series and reports because of the scarcity of research. And then I excluded adult populations, the research that used family-based treatment with other eating disorders, and those that reference to family-based treatment but primarily focus on other treatment methods. And what I mean by that is I think some of the research acknowledged, so they acknowledged that it's sort of widely used in eating disorders, but perhaps hadn't included a core element within their model of treatment. And here, just to demonstrate, I hope my cursor is working on this video I've recorded. So my database search across 3 databases yielded 188. And based on my sort of result and screening process, I ended up with 10 papers for screening, perhaps firstly demonstrating that although a growing body, you know, there's still a lot of work to be done to get that a really well-established peer-reviewed journal papers, but excuse me, a good amount there, sort of start off and see what this evidence base was saying. So I just wanted to show you that sort of the 2 main parts of data that forms you know, my paper and the sort of the points that provide implication for practice for those of you that are working with those with ARFID. So I've just got the general sort of characteristics, and I wanted the measures as well, because you know, a lot of them looked at weight restoration, but there's also the psychosocial and food expansion side of things. I just wanted to see the subtypes that were included, and just to get a good feel of you know, which cases have been presented and have had family-based treatment used. Just going to check what the time I'm on. Perfect. So here we go again. So just here, you can see that there's some multiple subtypes in studies, you know, mixed, aversion, and then just sort of to illustrate the sort of data that they captured within their studies. So that we've got 52 ARFID patients in our sample, a mean age of 10 years. Majority were sensory sensitivity, and one of the studies hadn't disclosed their sort of the subtypes within the sample, so I wasn't able to get that for that one. You know, the number of sessions across them was around 16.5 over a 6.3 month period, just to give you an idea of how it was applied and sort of the time scales. And here, just as a follow-on for the systematic review, treatment application sort of across the studies, and this is where I wanted to form how it differed. Perhaps, you know, were they following the family-based treatment ARFID model that Dr. James Locke and his colleagues had sort of adapted from the anorexia nervosa model. Some of them were novel treatment methods, so, you know, derived from the fundamentals and established theory behind the model, but actually adapted it to meet the individual needs. Was it using adjunctive therapy, so perhaps with cognitive behavioural therapy and medications, and with the family element as well? I just wanted to sort of bring comparisons across to make some conclusion for practice. So based off the 10 studies, you know, irrespective of the subtype, duration, setting or application, you know, all 10 of the studies provided support for the use of family-based treatment for treating individuals with ARFID who are in a paediatric population. As I've acknowledged in my sort of formulation of the systematic review, there was some methodological limitation, and because of the study design, the case series and reports. But these 10 papers really provided a preliminary descriptive evidence that really highlights the feasibility and effectiveness of using family-based treatment for ARFID. So the included studies reported improvement in either anthropometric, cognitive or food expansion measures at end of treatment. So really positive sort of findings there from the studies. And I just made note here that there are further control studies going to be needed with follow-up data where feasible. And I just highlighted where feasible there because I know that, you know, parents with their children accessing care want to be accessing the most, the sort of what would be perceived as the optimal treatment method. So, you know, it may be harder to have a control group that aren't receiving family-based treatment. So The non-comparative studies can be used there. And then the family-based treatment interventions, it demonstrated adaptability to a variety of clinical presentations and desired outcomes, and which is really good, going back to my earlier background, that these individuals are highly diverse in the way they present to practitioners, which I'm sure some of you have experienced yourselves. So just hopefully that was okay for a bit of background, just to how I formed the paper, and a little bit about what I wanted to try and understand to implicate practice for me in dietetics, but also for the other multidisciplinary team working within this area. So it was clear that based on this research, applying a family-based element to treatment individually or adjunctively with other methods had a beneficial effect on outcomes. So that was sort of answering one of my first objectives, how would it be best used? But it seems that there's beneficial effects from both sides. Giving the parent a key role in the earlier stages of treatment, just through education and increasing their responsibility as sort of being involved in is the treatment rather than sort of overseeing the treatment, really sort of proved to be a beneficial aspect in engaging and sort of creating that intervention for those with ARFID. And the use of a relapse prevention phase appeared to be useful. And just looking back at earlier literature, it's family accommodation, which is seen to be quite high in maintaining the negative feeding behaviours seen with ARFID. So, after that initial education and support is given, and if you're looking at sort of reinforcing goals and assessing the treatment gains from the start of treatment to where they were there, and then just keeping some ongoing parental support following clinical treatment. And what I noticed is if a treatment had terminated with the child or adolescent, I think some of them had provided some telephone calls to the parents just to sort of follow up and try and reinforce those behaviours and the importance of keeping the skills taught by the practitioner when they're discharged from the service. And just some further points to this, it appeared to be flexible and adaptable to a range of contexts and individuals, which, as I'm sure we know, is really important for this group. And the sort of a well-established part of family-based treatment with the education, blame reduction, but also raising anxiety about the condition and the importance of trying to sort of adapt these eating behaviours, really proved to be useful in the earlier stages, and it was flexible and adaptable throughout. So I mentioned earlier, there's Dr. James Locke and his colleagues have done what was called family-based treatment ARFID, but some of the studies actually developed a novel treatment method, such as space ARFID, PBT ARFID, so just the prayer, and they tailored these around the individual. So took the core elements, provided it in a treatment where the individual would benefit most, just based on what they knew about the background and individual nature of the person presenting and perhaps any other coexisting conditions, which really does highlight the benefit of placing families and caregivers at the centre of treatment. And further to that, I've made that point that with the coexisting conditions and sometimes higher complexity, perhaps anxiety, depression, and some of the adjunctive therapies were applied to this higher degree of complexity and experience success in their desired outcomes. So that maybe just a little think about, perhaps those that are, perhaps not as clinically significant or do not need an inpatient admission, family-based treatment in the earlier stages could be useful, but thinking about where this really does progress to really impair both physical and mental health, it can be used in this high degree of complexity alongside other forms of treatment, such as medications and cognitive behavioural therapy. Although it was difficult to review the individual effects of family-based treatment, even though it formed a core element, and it did seem to be introduced as a supplementary element. So those that are being treated, keeping the family involved, keeping them responsible, and being placed at the centre of the treatment. So, perhaps there's another way to look at it. Maybe it's not to be applied in isolation, but, it could be applied alongside other things as well, which really, again, comes back to the point of that I found that it was flexible and adaptable, just to meet the needs of an individual. So I'll just check what time I'm on here. Oh yeah, so doing good for time. So the further question for family-based treatment in practice, so after those implications of practice and sort of the preliminary evidence and the show of promise, I just wanted to make a couple of points that perhaps for us working in practice can keep sort of thinking about, and maybe have some ideas yourself. But the majority of the sample included in my research benefited from a focus on weight gain. So the pathway to treatment was as a result of physical symptoms. And as I mentioned earlier, the ARFID can severely impair psychosocial functioning. And I think sort of an anecdote to where a reference to that, Ursula has been on television to have a discussion about that. Somebody being within a sort of a healthy weight or perceived, perhaps on the centile chart, there's no sort of flags written up there for the practitioner. But it can result in significant nutritional deficiency and impair the psychosocial functioning without needing the need for weight restoration. So I think that sort of highlights the first challenge with sort of diagnostic classification and individuals who would benefit from specific treatment methods. So just tracking it back, so we've got the the complexity and heterogeneous aspects of the of ARFID and those presenting with it. Some challenges with the diagnostic classification. So, perhaps are people individuals being missed when they're being assessed, or it's hard for us to pinpoint right now who's going to benefit most from which treatment method. As NICE guidance recognises, they haven't been able to they haven't got the confounding evidence and peer-reviewed research to provide that at the moment. So, just to further question, if we're categorising the severity of an individual's ARFID based on weight alone, there is perhaps an element of missed individuals who could benefit from family-based treatment without the need for weight restoration. And it could be said, that the sample that I gathered and was eligible for my review just happened to have weight restoration. But that's clearly there's an unrepresented element of ARFID where significant deficiencies in its psychosocial functioning at the healthy weight category. But thankfully, there's lots of great work being going on, and so just by when I was putting this review together, Dr. Rachel Bryant-Worth and her colleagues, doing lots of great work and leading the sort of the evidence bases alongside James Locke and some of the other practitioners within this area. And apologies if I pronounced her name wrong, because she formed a very big part of this research. So, but at the moment, she's published the Peak at ARFID in Rumination Disorder interview, known as PARDI, which assesses the presence and severity of these diagnoses for evaluation and treatment planning in both clinical and research settings. So, this tool could be used universally to classify the ARFID patients suitable for family-based treatment. So just having a little think about that. I just wanted to highlight this infographic and this sort of diagram and model. Hopefully the video of this isn't covering too much up, but just to show you some of the work and really highlighting the complexity of the care pathway. So this is an outpatient pathway, and my cursor here is showing in the psychobehavioral side of outpatient intervention, includes family-based treatment, but you can see here the thought and sort of the thought process behind getting a patient to the right sort of treatment area, and the process of them being at the end of the patient pathway and at the start of the patient pathway. And as I was presenting some of the clinical implications to you, I just wanted to highlight this because it's really key in the ARFID evidence base right now. And really, it was certainly useful for me to see how perhaps, my systematic reviews looked in the family-based area. It's recognising this model, but, there's still some questions around, who's it beneficial for, and sort of how's it going to establish in the evidence base. So just a little summary to close off. It's clear that, family-based treatment, which is encouraging and educating parents to address the child's ARFID with support of the clinical team, is demonstrated its potential. Potential being the key word there. There's a lot to be said about the validity and sort of the design of the majority of the research in my systematic review, but on the cases used within the 52 ARFID sample, it's began to show some real promise for this treatment method within this population group. And it's clearly very adaptable to the individual needs of and situation environment of somebody with ARFID, which is really important. You know, sort of going back to this model here, thinking about the complexity and individual needs, and the team needed around somebody with ARFID, just to really address the feeding behaviours. So sort of that can show you perhaps how that can fit into that model and its flexibility. So the established model of family-based treatment is feasible with ARFID patients, and going back to that key point and the question from my research is, you know, further diagnostic and severity clarity in practice could really assist us with directing this treatment to those who will benefit most. Also thinking about capturing those with severely impaired psychosocial functioning and nutritional deficiency, but without being at a weight which sort of flags up in a centile or scale within the BMI category. Well, thank you very much, and I hope that was okay. You know, we're working to get a publication for this paper within a peer-reviewed journal right now, and I'm really hopeful it can form some of the evidence base in this developing body in this sort of really interesting and complex area, working in as a practitioner. As I record this, I'm hopeful I can answer some questions for you, and also as I record this, Ursula should be here for the Wednesday conference session, just to answer some further questions, as she's a specialist in this area and sort of perhaps answer some of the more complex areas of practice in ARFID. I hope you're enjoying the conference, and it's been an absolute pleasure to be able to have this presentation put forward to you in the conference.